This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Darryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Darryl Glover. Happy Tuesday. Super excited today because I get to hang out with an amazing lineup, a lineup of just stars that's here to really change the game, but most importantly, to make an impact in eye care. Friends and family, I'd like to welcome my colleagues, Dr. Brittany Wright, Dr. Jeffrey Fardink, and Sophia Johnson, an optometry student. How's everyone doing today?
We're doing great.
Great.
Fantastic. Well, again, I'm super excited to partner with each and every one of you to make an impact on this series that we have known as Grand Rounds with Eye Care Experts. And before we get started, I want to give special thanks to our partners in crime, Johnson & Johnson Vision. You see, Johnson & Johnson Vision understands that they need to do or make an impact in eye care. And they know investing in the future of eye care is what's going to help to protect our industry. And it's also going to help us to be able to continue to expand our scope and protect our rights, but it all starts with education. And today, that's what we're going to break down, is education. Before we get started, Dr. Wright, if you don't mind introducing yourself and telling us about your background and how you got in eye care, and then we'll just kind of work our way around.
Sounds good. Well, thank you, Dr. Glover. I'm excited to be here. As Dr. Glover mentioned, I am Dr. Brittany Wright. I'm an assistant clinical professor at the University of Missouri St. Louis College of Optometry, where I have the pleasure of teaching our ophthalmic optics course and lab, as well as working with our 3rd and 4th years in our disease clinic, as well as one of our community health centers. So I like to share with optometry. I found it a little later in life after graduate school. And so opportunity to bring that love of science and healthcare and just engaging with people, put that all together. So happy to be here.
Fantastic. Well, let's take it to Dr. Fardink. If you don't mind sharing your background. I know you were on our first episode and you really blessed us with your knowledge and your presence, and we look forward to that again. But for those that didn't make the first event, if you don't mind sharing your background as well, sir.
I couldn't wait to be back. I'm happy to be back again. I'm a graduate of the Ohio State University College of Optometry. I've been in Richmond, Virginia for 5 years now. I've got a 3-location retail-based private practice, and I focus on specialty contact lenses.
Fantastic. And last but not least, we have our student with us. Our student, Sophia Johnson, attends SUNY University. But if you don't mind giving us a little bit of your background and how you got into the wonderful world of optometry, and also touch on some of the leadership that you do in eye care as well.
Hi, everyone. I'm glad to be here today. My name is Sophia Johnson. I am a 4th year ODMS student at State University of New York, College of Optometry. My research focuses on digital eye strain as it relates to the 2020 rule. And I am currently the NOSA National President, and I'm super excited to be here with you guys. Thanks for having me.
Fantastic. See, we got everything covered from academia, from a professor, a student perspective, to, retail optometry, but retail that has a different spin. Retail that, Dr. Fardink is a master when it comes to contact lens. A lot of people don't think that you can do specialty contacts or play around with contacts and impact a lot of lives, but he is living proof. He does it day in and day out, and he has 3 locations. So make sure you soak up game, make sure you learn, because this crew of experts here is going to change how you practice moving forward. Dr. Fardink and I are going to drop off. We're going to leave it to the ladies to really get started with this case. So good luck. We look forward to learning a little bit more. Let's get it going.
All right. Well, Sophia, are you ready to work through our case here?
I am ready.
Awesome. Well, we will get started, of course, with just another thank you to Johnson & Johnson for their partnership in bringing this Grand Rounds concept to fruition in partnership with Defocus Media. So we are excited to get going. Again, these are the eye care panel that we'll have, and we'll bring Dr. Fardink back closer as we get to our management and some insights that we can provide from a private outside of academia setting. So we will look forward to him joining us back. So we'll start with the case, Sophia, and we'll kind of work through. So as you have questions or things you want to add, please do so, and I may ask you a couple questions along the way. So for our patient, we have a 31-year-old high school PE teacher. She's complaining or coming in with just irritated, kind of general complaint of irritated eyes. She says she notices some mild itching, a little bit of discharge, and some foreign body sensation with the lenses in or out. As far as pain, not a ton of pain, but just more overall irritation. As we start to talk with the patient, she shares a little more about just her contact lens history. So we learned that she's a current monthly lens wearer. We kind of tease out with conversation that she sleeps in our lenses occasionally. So not something that's a constant concern, but comes up throughout the month. Not really sure about contact lens solution. And also, as we start to have better conversation and engagement conversation with the patient, we find out that during the day, they have to take their lenses out and kind of re-wet them throughout the day. So with that information, kind of pretty general stuff, what kind of questions or what are you thinking about as this patient sort of sits in your chair with these complaints?
Yeah, I think I'm thinking about a couple of different things. I probably want to ask her, like, what is she using to re-wet her lenses? Is she using that contact lens solution? Is she using a different product there? And then I'd also like to know if she has any seasonal allergies or any allergies at all.
Yeah, absolutely. So those are both good questions. So when we hear that complaint about itching, that usually triggers some sort of allergic type of condition or allergic related condition. And then definitely when we hear re-wetting or a patient needing to re-wet their lenses, now we're starting to add in some things about quality of life and, how bad is this re-wetting disrupting your day-to-day activities? So things to keep in mind as we get towards our management options for the patient. So as we get the patient, we get our entrance testing done. It's kind of a medically focused visit based on the complaint today. So while the patient comes in, she's got her contact lenses in, so we go ahead and have her sit behind the slit lamp and we take a look. And this is what we see. So as you're looking at this lens on the eye, what are some things that kind of jump out to you just off of the view that we have here?
Definitely the poor tear film quality. You kind of just see the streaks in the lenses there, or the lens there. And I believe I'm also seeing some deposits on the lens.
Yes, absolutely. So with her coming in with the lenses, and we may even ask, how old is this current pair of lenses? And that can give us an idea about what does this lens wear cycle really look like for this patient. But definitely kind of this oily layer, tear breakup situation going on the surface of the eye. So something, again, as we start to think about management and some recommendations, something that we'll keep in mind. But now we get that lens out of the eye, and with all of our contact lens patients, we evert the upper lid, and this is what we see. So again, describe what it is you're seeing in this particular case.
I'm seeing just a really rough, bumpy palpebral conj with more severity towards the crease there. Yeah,
absolutely. So we're looking at, as we evert the lid, you've got this rough, irritated surface. What I like to tell students when we see this, or when you evert a lid in general, is looking at the crease, you just kind of get the contrast between the elevation of the little small bumps or that rough surface against the cornea. So you can kind of define that a little bit better than if you're looking at a flat plane of the superior tarsal conj. So using that contrast to help determine how smooth or rough is that tissue. So if you had to put a name on what we're seeing, you've kind of described it based on the visual and based on what it is, but how would you define this? What would you call this in your patient?
GPC, or just very large papilla. Mm-hmm.
Yes, absolutely. So GPC, or giant papillary conjunctivitis. Mm-hmm. So let's talk a little bit about GPC, which is still quite common in many of our patients today. So we'll start with grading, and I tend to recommend or utilize grading scales really to help with determining the severity of the disease, but also the intensity of the management that may be needed for the patient. So we won't necessarily go through all of these different grades, but I think when we look at grading, the way this becomes useful clinically and in practice is it gives you an opportunity to start to categorize where the observations you're making in a patient, where they fit in a scale of severity, because that will then start to build your management toolkit and what options you have based on where they fall on that grading scale. So in our case, we did consider this patient to have roughly grade 2 to grade 3. There were some larger papilla. We didn't see too many mucus strands when the lid was everted, but the patient did report some mucus discharge, which leans us more towards that grade 3 standard there. And then with GPC, we also know that contact lenses aren't the only cause of GPC, and they're not going to necessarily only occur in a contact lens wearer. So here I just wanted to present just a few different differentials that you might consider. Our patient history and our discussion with the patient kind of gives us some information about defining whether or not these are high differentials on our list. So things like VKC or AKC may fall lower on our likelihood because of the patient's demographic, their age, their history of atopic conditions. You mentioned seasonal allergies before. So if we've already identified that this patient doesn't suffer from seasonal allergies, maybe that's again falling lower on our differential list. But then we look at follicular conjunctivitis, which is a different condition than our papillary conjunctivitis. But I do find that, especially as a new or younger clinician, that these sometimes can get blended together just because it's hard to define or hard to see the difference. So I'll put you on the spot here, Sophia. When you're looking at a patient and you're trying to determine, is it a follicle, is it a papilla, what might you be looking for to help distinguish that?
Yeah, I would definitely be looking at the blood vessels to see, are they in the center or are they kind of going around kind of that raised area, that raised bump? Mm-hmm.
Yes, absolutely. So the location of the blood vessels is important. With papilla, you actually get the sort of vascular core that sits at the apex or is visible from the apex of the papilla, versus follicles, which the vascular is just disorganized. So it kind of runs parallel with those follicular structures. So I think looking at the blood vessels is very important. The amount of injection may influence that a little bit, but if you can identify vascular presence, papilla also tend to be a little more defined in that you can sort of see individual papilla, whereas follicles kind of coalesce together. So they kind of blend together, look a little more fluffier, less defined edges. So certainly things to keep in mind because those managements may look very different if we're looking at a follicular conjunctivitis compared to a papillary one. All right, we will keep rolling here then. So with our patient, as you mentioned, we identified giant papillary or what we're calling contact lens associated papillary conjunctivitis. And we made that distinction because we had identified the other causes, other more common causes were not considered relevant for this particular patient. So we decided to, and after talking with the patient, we discontinued contact lens wear. We did start the patient on a topical antihistamine and mast cell stabilizer, as well as a topical steroid. And that was influenced by the severity of the papilla, the patient's encouragement that contact lens wear was really important to her, and the need for a sufficient and efficient resolution of the inflammation that was occurring. So we looked at those as options for management. We also added a preservative-free tier because, again, as you discovered and mentioned earlier, Sophia, there was that irregular oily tear film that we saw on that contact lens. So we definitely want to find a way to start addressing that ocular surface concern. set the follow-up time at about 14 days to give enough time for the management to start working, to see some resolution, and to then start to plant that seed about contact lens care and next steps for this patient. So as you look at the plan here, any questions or anything that comes up related to our initial direction?
Yeah, I would definitely think about the patient in terms of their needs. Like, are they, in terms of the contact lens holiday, right? We should all take one of those. But if I have a 7-diopter myope in my chair, I'm kind of thinking about, okay, do they have a backup pair of spectacles? And if they don't, what are our options? What else can we do for them?
Absolutely. I think that is so important. Patients, as we all know, are not just a set of eyes. They have a life outside of our exam room, and we have to consider how might the decisions we make in that exam room influence their day-to-day function and their day-to-day quality of life. So that is definitely an important part of this conversation, is what does removing the contact lens wear look like? In some instances, it's necessary and you've got to find alternative options. But in other cases, you may have some amount of flexibility to work with the patient to find a balance that will give them what they need for visual function, but also will allow the health of the eye to be addressed. All right, so patient comes back. And before actually we get to our patient coming back, just a little bit about the pathophysiology of GPC. So in our case, mechanical insult is one of the more common causative aspects of GPC. There's still some discussion and debate about true underlying inflammatory and immune mediators that contribute to the presence of GPC, but mechanical injury or mechanical insult on the conjunctiva is a pretty common understood causative aspect. So we have friction between that contact lens, superior tarsal conj, triggers an immune response, which then you get this hyperactivity of those immune cells. And now we start to have collagen growth, which forms the actual papilla. So there is some time in there in which that may take place, but there may not be symptoms that the patient is feeling in those moments. And so this is where patient education, really comes in to ensure that we aren't seeing patients develop to this level of severity. And so we see our patient back. Symptoms are much better. So in this case, our management was helpful. And we talked about, at this point, things that the patient should be watching for. So they reported not much itching, discharge and redness had resolved, and the patient reports that she was able to take the medication as prescribed. On slit lamp, we do still see a few papilla present, which we would expect. Papilla can hang around for up to 3 months in some more severe cases, and especially in someone who's been a contact lens wearer for a very long time. So we wouldn't expect complete resolution, but we only see a few small papilla remaining. Symptoms have resolved, and overall ocular health looks much better in this patient. And so here we have a picture. So if we were to describe this conjunctiva superior area compared to previous, would you consider this, pretty resolved in this case?
Yes, nice and smooth.
Yes, absolutely. So nice and smooth. And you can even tell as you're looking behind the slit lamp, even if you're looking in this area where you have this hyperreflectivity, you just notice a much smoother reflection off of that surface as opposed to our previous photo. All right, so at this follow-up here, now that we've gotten improvement, we talk with the patient about just continuing the topical antihistamine and mast cell stabilizer just to help with the kind of trail off residual immune response that may be occurring as a result of their old contact lens. Talked about a preservative-free. And then in this case, we do a pretty quick taper because much of the immune response has settled in this case. And at this point, we start to have the conversation about the contact lens aspect of what sort of caused all of this to occur, or at least encouraged a lot of what we're seeing to occur. And so we will look at bringing Dr. Fardink back up with us so we can talk about just management and things he may be considering in a case like this. So Dr. Fardink, I'll ask you to share in your patients where you see this GPC occurring, how are you having those conversations? What is it about the lens itself that you may be looking to modify to get these patients some relief?
That was a great discussion. I think everything that you did in this case is very much steps that I would follow with my own patients. When I'm talking to a patient about a case like this, I'm often wondering about their behaviors and what changes are we going to make this doesn't come back. So in this case, you have a patient who's removing their lens frequently to re-wet the lens. What I often see in patients who have this is that they're not removing their lens much at all. Maybe even not for nighttime sleeping. So often you'll get patients who've worn lenses for years, and then you give them, say, a new set of contacts to put on, and they're in the contact lens room taking forever putting the contacts on because they seem like they're not very good at it. How are they not very good at taking the lenses off and on if they've worn them for years? That's a good indication that maybe this patient isn't being very honest about how often they remove their lenses. They're probably putting them in at the beginning of the month and taking them out at the end of the month, the end of 2 months. So behaviors like that are things you can pick up on with your patients. And the main thing with a patient like this that I'm having the discussion about is just switching the lens type to a daily lens. Getting that patient into a daily lens. I've seen GPC in daily lens wearers. I've seen it, but it's much, much less frequent. And generally, it's when that patient is really abusing the dailies, wearing them for longer than a day and so forth. So that's the conversation I'm having with this patient is we're going to take care of this with some medication, with a little contact lens holiday. We're going to get you into dailies. We're not going to have this problem again.
Absolutely. Very good points. And it's certainly something as we think about the design of contact lenses and what the different designs can offer. If you are concerned about, just the mechanical irritation, maybe you're considering what is the lens edge design? What does that look like in the particular lens you might be fitting the patient in? Modality, as you talked about, Dr. Fardink, having that more frequent replacement is a significant way to reduce this occurrence. So ensuring that the patients are wearing the lenses as you've indicated or as you've instructed based on how this will provide the most health for the eye.
I completely agree.
And then the last sort of question I have for both of you is how are you having these discussions about just in general safe contact lens wear for the patient? We often will share, we know it's a daily, so it should just be pretty easy and clear that we want them wearing it daily as well. So how are you ensuring that patients have the right understanding of wearing a daily lens like a ACUVUE 1-Day Moist or the new 1-Day Max? How are you integrating that conversation into your patient education?
Well, I love the first bullet point up there. You definitely do not want to shame your patients. And you also want to get your patients to be honest with you. And a great way to do that is to make them not feel shamed. So I always reassure my patients that, I'm here to educate them. I'm not here to shame them. I'm not personally invested in their behavior. I just want them to do the things that's going to make them happy and comfortable in contact lenses. So when you have that conversation from that perspective, people tend to be more honest and tell you maybe some of the bad habits that they have. And yeah, GPC itself, when you're not wearing a contact lens, typically isn't super uncomfortable. It's when you have the lens on that it starts to become really uncomfortable because those big bumps are catching the edge of the contact lens, and that constant interaction with the lens edge is really uncomfortable. So patients after recovering from GPC will really appreciate lenses that have a design like Johnson & Johnson lenses have with the infinity edge design, that really tapered edge profile really minimizes lid interaction, especially in patients who are recovering from GPC. So switching into a lens like the OASYS 1-Day Max you mentioned is a great idea there.
Yeah, and Sophia, anything you may be considering as you talk with your patients and you're considering that transition to, a daily or a more frequent replacement cycle?
Yeah, I often talk about my own experience, right? So I tell them how I'm in a daily lens, and I talk to them about how, it helps me and helps me to be a lot more responsible with my lenses, because I've been in lenses for a very long time as well. And then I think the way you ask the question, like how often do you sleep in your contact lenses instead of do you sleep in your contact lenses, is very different, because it kind of opens it up saying, I know you might do it sometimes, I'm kind of opening that floor for you.
Absolutely. I appreciate all of the feedback and the comments there, because it's certainly important that we're having these authentic conversations with our patient as we're making recommendations about particular lenses, understanding that edge design, the science behind that, understanding the science of the makeup of the lens. Does it have anything that promotes good tear film stability or good ocular surface comfort in the lenses? So those are all things to definitely be keeping in mind and encouraging and providing to our patients.
I see there's a question here about is grade 1 GPC enough to have the conversation to switch a patient into dailies? Certainly with any case of GPC or these symptoms, I'll always bring up the discussion of, are you interested in switching to a daily contact lens that might minimize your discomfort? Definitely the patients who have more advanced symptoms and issues are going to be more motivated to make that switch, but certainly I'd bring the conversation up with a grade 1 patient and see what direction they'd like to take their care.
Awesome. Well, thank you for that. I certainly do find that the earlier we can have these conversations and address the concerns, even if it is a grade 1, the less likely we are to see these advance to much more significant disease. So if you're seeing any signs of GPC that could indicate that the patient may not be wearing their contact lenses appropriately, having that conversation and making those adjustments earlier, the better, for sure. All right. Well, I believe that is all that we have, Dr. Glover. Any additional comments or questions?
Hey, fantastic. I actually have a question, because I always wrestle with this in patient care. Dr. Fardink, you mentioned affinity design, edge design. Like, how technical do you actually get in the exam lane when you're having a conversation with the patient, right? I know we have our engineers and we worry about them and we got to break it down, to the T for them. But how technical are you getting with that conversation? And are you using any visuals to show the patient as far as maybe pictures online or some type of document that you may have put together? How much are you getting into the detail, the nuances when it comes to having these conversations?
Oh, yes, absolutely. I mean, sometimes I'll talk to my colleagues who are frustrated about the attitudes patients have about contact lenses or the misconceptions that they have. But if we don't educate them and break them of those misconceptions, what do we expect them to, what do we expect, right? So I definitely will get into the woods here describing the technology of the lens with patients, and patients really seem to accept it, and they really seem to appreciate it. They come to us for our knowledge and our expertise, and they're happy to get it. And if I get a patient where I feel like it's going right over their head, I can, dial it back a little bit, but that rarely happens. Generally, they're excited to know why a certain change is going to help them, why they're making the effort of a change. So it does get patients more invested in their care if you can explain, why you're making a change that you're making, instead of just saying, we're going to do this. You got to tell them why you're doing it.
Yeah, and I love that, because what we have to realize is that we're the experts, right? Patients are coming to us because they want a solution and they know that you are the expert. And when it comes to having, all these different types of contact lens design, it is really important to know the difference between, different brands, what brand is superior, and what brand is going to work with that patient that's sitting in front of you. Because all patients are different. Not every lens is going to work for every single patient. So having a good overview, having a good understanding, and being able to communicate clearly in that patient's language makes a world of difference. And sometimes you may be able to have that language where you're getting very in the weeds and in the details and use, the technology that they probably Googled before they came in. And then sometimes folks like me, I got to see a picture. I got to see what I'm looking at to understand what's going on. So, something that I would love to share with the students, with the new graduates, and even with our seasoned ODs out there, just make sure you understand that patient that's in front of you and make sure that you speak their language as well. Now, it looks like we have a question here. How do you navigate a situation when a patient needs to discontinue contact lens but does not have a pair of backup glasses? This happens every single day, and this is a great question. And I would love to get everyone's feedback in regards to this question here. So Matter of fact, Sophia, maybe you can start off with it because I know you're still getting in it. How do you look at this situation when you see this case? Do you get freaked out, or do you have a solution to be able to help these patients?
I think I would start off by asking them what their day looks like, right? So if they're maybe a student who needs to study, or maybe they're going to class and need to go about, it's only a few hours a day, I might, say, okay, you can wear them for that few hours, try to take them out, only a couple hours a day, and, make sure you're using your drops and the regimen that we gave you. So yeah, I would look at, what does their lifestyle look like? What does their day look like? Are they at home? Maybe they're working from home. They may not need their glasses as much when at home because they know their surroundings. So I'd probably just try to understand, where they're coming from, and just say, okay, maybe a couple hours a day, and try not to be in them the rest of the day.
So
I'm open to hearing what everyone has to say.
No, but I love the direction that you're going. Understanding your patients' lifestyles and what they do day in and day out really helps to buy loyalty, but also helps for that patient to truly follow that treatment plan. So understanding what they do really makes a world of difference. Dr. Fardink, Dr. Wright, I'd love to hear your feedback in regards to this case.
I will send patients before they go to the pharmacy to get medication. Sometimes they're going to go to a dispensary that has a 1 hour optical, because sometimes a patient with this is going to go out and buy a pair of glasses right now because they can't wear contacts. They need to wear glasses. So yeah, I've definitely had patients with GPC. They're going to buy a pair of glasses first thing because they need it. And this also brings back something that Dr. Wright brought up earlier. I really want to give Dr. Wright big props for mentioning that you have to treat patients practically. Giving the patient steroids in this case, I think, was a great idea to really help speed up the resolution. You don't always have to do that. I definitely will play. I'll use steroids a bit more, a bit less conservatively than some of my colleagues sometimes, and jump to it. And I have had cases like this. I don't like to do this, but I have had cases like this where I've got a patient, say, who's an NCAA basketball player. They need to wear their contacts for a game or something. I've given them dailies to wear while they're recovering from GPC for that game, just because I know they need to do something. So treating your patients practically, maybe not the best way sometimes, is still important to make sure your patients have the options they need to get to heal properly.
Absolutely.
Dr. Wright?
I will add, I have had a few situations where, I'm encouraging the patient, hey, can you dig around, find an old pair of glasses? Because usually if they're, a pretty decent myope, they've got an older pair that might be a half diopter or quarter diopter off from their current glasses. So we're starting there. If we have, because sometimes I'm in populations where the getting new glasses quickly may not be an option. And so we're looking at, okay, we've got this set of donated frames, and I know what the prescriptions are. Is there a way I can grab these quickly? Because they only need them for a short period. And then to circle back, we are having the conversation about how important having glasses is, and now they get a full dose of it when they can't wear those contacts. So I really think it's about communication, figuring out what is it that the patient needs, and how do we kind of bridge those two ideas together.
And I think that's important, right? When patients come in and they're contact lens wearers, yes, they want their contacts, but we always, always, always have to stress the importance of having glasses. Every patient needs to have glasses. Every single patient that walks through the door, because you never know what may happen. You never know. So just always make sure you have that conversation with your patient and give them scenarios. You may travel and you rip all your contact lens. You may get an eye infection or have GPC like with this patient here, but you want to make sure that you're realistic about what can happen. And yes, it is an additional expense, but it's your eyes, right? This is what's helping you to make money. This is what's helping you to live your best life. So, just really getting down to, expressing the importance of it, and bringing maybe some examples in a play makes a world of difference. Now, we got another question. Patients. I've been in clinic today, so excuse me. But we got our colleagues, our students out here that have tons of questions. Kylie Stout, thank you for tuning in with us this evening. She asked, would something like antihistamines be helpful? Actually, you know what? Let me step back. She asked a question prior to that. Random question, first year student here. So please do not answer this if it's not related. How do seasonal allergies play a role in GPC? since the patient is a PE teacher who works outside?
Absolutely. So part of it is, so with papillary conjunctivitis, this can occur. Typically with contact lens related, we tend to see it isolated more to the superior conjunctiva. Whereas for our patients with allergic, it can affect the surface, the internal palpebral conch, superior and inferior. So usually presentation and location helps with that. And just identifying history wise, do they have a history of allergic issues in the past? So have they had seasonal allergies and other symptoms of seasonal allergies, just not the ocular findings?
And as far as antihistamines go, antihistamines were used in this case actually, but to give a more in-depth answer, when you're using steroids, you don't always have to use the antihistamine at the same time. Definitely a good idea to use it in conjunction, and especially long-term. You can't use steroids long-term, so using steroids to kind of put out the fire and then keeping the symptoms gone with an antihistamine in a more long-term basis is a direction I might take in certain patients.
Absolutely.
Then we have another comment here from Rena Shilan. In the case of the patient not having backup specs and needing to wear contacts a few hours a day, do you recommend lubricating drops that are safe for contacts to make the patient more comfortable?
Sure, that's not a bad idea. With dailies, you don't even necessarily need them, even with a GPC like this, especially if you've got some of the great lenses with the more advanced PVP methods like the OASYS 1-Day Max. Very few patients, even with cases like GPC, will need a lubricating drop. And also, this patient is using an artificial tear that's preservative free. A lot of the contact lens drops out there, you want to make sure that they're using ones that are safe. A lot of times people are using contact lens drops that have preservatives, even though that's not something that I would ever recommend. So I would hesitate to have them use any sort of drop with the contact lenses on in that particular patient. And that was just for a very short-term period. So they probably didn't really need them.
Yeah, I'd agree. That's about the approach I would take.
I love it. I love it. And we have another comment here. Good information about RX and that steroid. Had a similar case where I only offer the antihistamine, artificial tears. She'll keep that in mind. So fantastic. You see you guys out here preaching the gospel. People are learning, they're listening, and they're going to implement. That's the key, right? Don't just tap in and tune in and watch. Actually go tomorrow and practice and implement some of these things that you've heard these experts on the stage have discussed. Stephanie Brown, looks like she has a comment here as well. Let's see. For children in my practice, we will not fit contacts if they do not have a working pair of glasses. It's not hard to get parents to comply. I love that point. And the thing is, when you start talking about when you start talking to parents about their kids and their ocular health and potential loss of sight, it's not hard to have that conversation. They want to do what's best for their kids. And as a matter of fact, I know personally when parents come in and we start talking about the concept of contact lens, they are the ones telling their children that, hey, you still need glasses. You still need backup glasses. You cannot wear contacts 100% of the time. So, I love that approach. What do you guys think in regards to that? Is that too aggressive, or is that just right to really secure, number one, a habit for the patient, but number two, to secure the health of the patient as well?
That's a great
I think it's appropriate.
Yeah,
I think it's great to start it off that way from the beginning. Existing fits, having a standard that they have to comply with. I think it's
I always tell patients contact lenses are a great adjunct to glasses. They're not a replacement for them, for sure.
You got it. I love it. Well, hey, this has been fantastic, everyone. We've had some great dialogue, some great comments. Everyone has, brought some value to the conversation today. I hope that we can all go out in the real world and implement these things. Consider steroids. Look at the type of contact lens. The ACUVUE 1-Day Moist is an amazing option that I use in my office, especially, when I have problems with GPC. That Max, it's a new lens that's out, the multifocal option. I don't know about y'all, but everyone I put that ACUVUE Max, OASYS Max on, that's a multifocal, regardless of the age of that presbyope, it's game changing. I don't know what's going on or what they did, but that lens has change the way I prescribe when it comes to multifocal? I mean, has your feedback been pretty much the same as well?
Definitely. There is something about the way that the optics behave in that material. I don't know if it's the modulus, something about it where, yeah, the improved contrast sensitivity, it works even better than I've had in the past with, say, the similar design in the moist. So very happy to see those even improved results with the OASYS 1-Day Max multifocal.
Yeah. Sophia, have you had the opportunity to fit that lens yet?
I have not. I am in a referral center, so I have not had that opportunity yet.
Yeah, it's going to change your world, just FYI, so be ready for it. Well, thank you again for tuning in with us. As promised, we do have a raffle, and we have 3 folks that have won the raffle. $100 gift cards from Amazon, and we're doing 3 of them every single episode, all right? And we got 4 more episodes to go, right? So the winner, the first winner is Carly Poskachil. Sorry if I did not get that name right, but Carly Poskachil. The second winner is Jody Hung. And then the last one is Louise Espinoza. I will email you personally and make sure that you get that gift card. I want to thank everyone for coming on this evening. This has been fantastic. The expert panel, thank you so much. You're getting love from all across the world. Everyone is thanking you out there. You're getting a round of applause. There's Carly. Hey, thanks for tuning in. We'll get it to
congrats.
Good job. Pleasure to be here. Thank you guys so much for
Yes, it's a pleasure.
Yeah,
Thank
and it looks
you.
like we have one more comment here. There are programs out there for free eyeglasses if money is a factor. We just did a free eye exam and 2 pairs of glasses for kids 6 to 16 earlier this month. Hundreds of glasses. You know, this is why I love eye care, because everyone that's in this profession understands the value that we create. And we understand that we don't have to chase the money. If you do what's right for the patient, the money will chase you and you'll never have to worry about a dollar in your life.
100%.
Make sure you put patients first. Put them on that pedestal. Practice empathy. That doctor-patient interaction, that conversation, that's what's going to elevate your practice. And that's what's going to continue to elevate our profession, because we're able to spend that quality time with the patients. Again, lots of thank yous here. Thank you so much for tuning in. We do have another episode. The next one up, I'm going to bring this back up here, is November 16th at 8 p.m. Make sure you tune in. We'll release the Eventbrite here sooner than later. I want to give another special shout out to our partners over at Johnson & Johnson Vision. We really appreciate you finding that gap and making sure that we can bring a team of experts on to really have that conversation. Thank you, Dr. Wright. Thank you, Dr. Fardink. Thank you, future optometrist Sophia Johnson. We look forward to tuning in with everyone next time. If you ever need anything, feel free to reach out to myself or one of these experts on the stage. Stay healthy, stay positive, stay blessed. And until next time, peace. Have a good one. All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the D-Focus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars and make sure you follow us on all social media platforms: Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at D-Focus Media on all platforms. And until next time, be sure